Welcome to Pediatric Grand Rounds. Before we get started, just the usual reminders from me. Please make sure you're muted during the presentation. If you have questions or comments, please add them to the chat with everyone box at the bottom of your screen, and I will share those questions and comments with the speaker during the Q&A at the end of the hour. At that time, if you want to be brave and unmute and turn your camera on so we can have a discussion, we welcome that too. You'll be getting an evaluation by email from our team in the next day or two. Please make sure to fill that out as it helps our team plan future grand rounds. And finally, a disclosure, the planners for grand rounds are the planning committee have no relevant financial relationships to disclose. So now I will introduce our fabulous speaker for today. Dr. Sarah Golub is an assistant professor of pediatrics in the Division of Adolescent Medicine here at Seattle Children's Hospital, where she currently serves as clinician educator and associate fellowship program director. Her clinical interests are in adolescent sexual and reproductive health, including contraception and menstrual management. She is passionate about teaching, and her academic and research pursuits are focused on medical education and training, both globally and locally. Welcome, Dr. Golub. Thank you so much, everybody.
Thank you so much, Suzanne. I'm really excited to be here today, and I can't wait to talk about one of my favorite topics, which is contraception for adolescents. So I do have some disclosures that I am a local PI on an investigator-initiated grant through Organon for a national adolescent long-acting reversible contraceptive collaboration, but I received no personal funding through this grant. I'll also be using some brand names of medications and devices in this presentation, but it won't at all be affecting my talk. So learning objectives for today, we will analyze some national and regional trends in adolescent sexual and reproductive health. We'll also, I'm seeing an annotation request. Okay. We'll also explore contraceptive options available to teens. We'll talk about the risks, benefits, and medical considerations for different methods. And we'll talk about non-contraceptive benefits of hormonal methods that are beyond just birth control. Oh, okay. I'm not sure about, let's see.
It looks like you may have stopped sharing, Sarah.
Yeah, because there was some request for annotation and then it stopped my presentation.
Oh, no.
Okay. Let me see if we can do that.
Okay, Grand Round viewers, you don't get to annotate.
Okay, let's see.
Please refrain from annotating our presenter's presentation. If you did that by mistake, it's okay.
Okay, does it look okay now?
Yep.
Okay, perfect. Sorry about that. Great. So to set the stage for why this is a topic of importance, according to the World Health Organization, we know that at least 10 million unintended pregnancies occur each year among teens in the developing world. And we also know that complications during pregnancy and childbirth are a leading cause of death in 15 to 19-year-olds globally. And of the 5.6 million abortions that occur each year among teens, almost 4 million of them are unsafe, contributing to maternal mortality and morbidity and lasting health problems. And evidence shows that teens who give birth face higher obstetric risks, and we know that babies of teen parents also face higher neonatal risks. So teen pregnancy in the US have been declining, yet they still rank highest among all developed nations. So this graph from Guttmacher Institute shows trends in pregnancy rates from 1973 to 2017 among women by age group. So we see the top bracket of women aged 20 to 24, followed by 18 to 19-year-olds, 15 to 17-year-olds, and then the bottom line of under 15-year-olds with overall downward trends. And between 1991 and 2020, the teen birth rate in the US has actually declined by about 75% nationwide, but progress has been uneven. And this figure taken from the Pew Research Institute looking at teen birth rates reveals that Across race and ethnicity, rates have continued to decline, but inequities certainly do persist. And this slide is showing CDC data looking at the number of births per 1,000 teens aged 15 to 19. And with a national average of about 15.4 births per 1,000 teen girls, Mississippi has the highest rate at 27.9 per 1,000, and Massachusetts with the lowest rate around 6.1 per 1,000. And Washington is ranking about number 38 out of 50 states at 11.3 births per 1,000 teen girls. And again, this graph just illustrates kind of where Washington stands in the pack, trending downward from 1988 and kind of living around the lower 1/3 of all states. So why are we seeing such drops in pregnancy and birth rates in the US? Well, we'll look at the behaviors that we know about. So the Youth Risk Behavior Survey shows us that we've seen some declines in teen sexual activity. In 2009, 46% of teens reported having sex, compared to 38% in 2019, which is our last set of published data. And youth are also reporting having fewer sex partners. So in 2009, about 14% reported having 4 or more sex partners, compared to only 9% in 2019. We are also seeing that fewer youth have been using condoms lately, down from 61% to 54% in this time. And another reason for the declining overall rates is an increase in contraceptive use, as shown here in data from the Youth Risk Behavior Survey as well. So this figure shows a change in percentage of prescription contraceptive use in select states throughout the country. And between 2015, which is represented in the lighter bars on the left, and 2019, the darker bars on the right. Now, after sharing these trends and data, I also want to pause for a moment and highlight that there's existing controversy challenging the use of unintended pregnancy as an indicator that we should be chasing. Advocates of reproductive justice criticize that a focus on treating this decline in unintended pregnancy as a positive public health outcome prioritizes more effective contraceptive methods regardless of patient desires, contributes to stigmatization of fertility among already marginalized groups, including adolescents and people of color, and assumes that we should be avoiding abortions, which is an assumption that is rooted in and contributes to abortion stigma. So as such, there really has been a shift towards expanding reproductive autonomy and not just reducing unwanted pregnancies. Advocates of this perspective support the idea of developing other measures that can take into account autonomy in choices regarding abortion and contraception in the future. And it's just good for us to remind ourselves that not all adolescent pregnancies are unwanted. And an important part of any discussion around contraceptive in teens is the concept that sexuality is actually a normal part of human development. It's healthy to want to explore sexual curiosity and intimacy during adolescence, and inviting conversations about this with your teen patients might make them more likely to be open about what they're thinking or what they're doing. And I have to say that, yes, your patient with chronic illness, maybe on a teratogenic medication, is also likely thinking about and maybe having sex. And you might not know unless you ask. But we are here in adolescent medicine to help support you through these conversations and support your patients as needed. So when we think about sexual and reproductive health outcomes in adolescents, it's important to consider the unique barriers that they face in receiving care, including awareness of services available, access, including transportation and potentially cost, confidentiality and privacy. They face stigma and possibly even fear of judgment from medical providers. So it's helpful to mention confidentiality laws as they differ from state to state. In Washington, age of consent for sexually transmitted infections and HIV treatment and testing starts at age 14. But for reproductive health, including contraception prescription, there's no age limit. There's no parent permission required for abortion and no mandatory waiting period. And the consent for mental health treatment, as well as for alcohol and drug treatment, starts at age 13 in Washington. So, what are reasons why our patient might even be seeking contraception, or what are some reasons that you might be bringing it up with them? So, certainly, as we've alluded to, pregnancy prevention, they may be hoping to prevent a pregnancy, but they also might be seeking support around heavy, painful, or irregular periods. They may have mood fluctuations with menses that they're looking for help with. They may desire complete menstrual suppression, or maybe they have bothersome acne or unwanted hair growth and they're looking for hormonal management for this. So let's talk about the first case. We have a 17-year-old cisgender female who comes in for her routine physical exam. She's sexually active with males and she is not trying to become pregnant. So you ask what she's doing to prevent a pregnancy, and she states that she uses condoms some of the time. So you offer to talk with her about her options for contraceptive methods. So, where are we even going to start in thinking about how to help our patient select a method? So, first and foremost, we really want to know what their goals are. Are they here because they want to prevent pregnancy at all costs? Do they really desire kind of the best control over menses? And what are they hoping for? Next, do they come with a method in mind? It's really important to have a sense of this before you kind of run through your agenda, because for all you know, they may absolutely not be interested in a method that's placed in the body, or have heard kind of horror stories about certain methods. So it's good to have an idea of what they're thinking before you start talking. And then, are there any medical considerations? So do we have to worry about any kind of underlying conditions that might make certain medications unsafe? And then we should be thinking about which are the most effective methods, again, for their goal. Is that for amenorrhea or pregnancy prevention? And how can we help them attain that? And are they interested in a shorter term method or maybe a longer term method? And how can we help them decide around that? So in further discussion with our patient, she shares that she's actually had a lot of difficulty adhering to a daily pill regimen in the past and is hoping to avoid this. She also shares that she has a history of migraine with aura. So how does this impact our counseling? So let's talk about some medical considerations. So contraindications to any hormonal method that includes estrogen, so any combined hormonal method, includes high risk of thromboembolism, migraine with aura, like our patient, uncontrolled hypertension, and any history of complicated valvular or ischemic cardiac disease, active liver disease, and then personal history of breast cancer, which certainly we hope is not as common in our patient population, but okay to have a family history of breast cancer. So this brings us to the very busy and overwhelming looking CDC's medical eligibility criteria summary chart, or the MEC. This is a very useful tool that we rely on heavily for considering safety of different contraceptive methods. And I'll orient you to this chart. So on the far left side, we see the first column that lists various medical conditions or characteristics, followed by subconditions to the right of that. And then along the top in the blue border, we see different methods, starting with the copper IUD, the levonorgestrel IUD, the implant, depo-deoxyprogesterone acetate, or the depo shot, progesterone-only pills, and then combined hormonal contraceptives with estrogen. And then underneath that row, you see the I and C designation, which refer to initiation or continuation for each method. So the MEC classifies different combinations of conditions and methods with a grading system. So a classification of 1 or green means that there's no restriction or concern and that the method can be used safely. 2 suggests that the advantages generally outweigh the risks. 3, the risks probably outweigh the advantages. And a classification of 4 or red indicates that it's really an unacceptable health risk and this method should be avoided if possible. Fortunately, there is a very user-friendly app for this, which is free. It is the CDC MEC app, and we can see at the top of the kind of home screen here, you can search by either condition or by method. You can also choose SPR to view the selected practice recommendation regarding various methods and also provide some tips on troubleshooting different challenges. And so if we opt to select by condition, this is the view that we see, and we can scroll down to find our condition of choice or subcondition. And here, this is if we have selected headache with a subcondition of migraine and a further subcondition of aura, we kind of see the recommendations here. So we see that at the bottom, we see the combined hormonal contraceptives have received a red or 4. So we really need to avoid that method at all costs, but we have other options. So all the other methods look like we're green in the clear. And the nice thing about this app is that if you click on the right plus circle in purple, it actually provides clarification and evidence based on each recommendation if you're curious. So thinking about which are the most effective methods for birth control for adolescents, this is a really wonderful visual from bedsider.org, which many of you may be familiar with and may use in your clinics. But it shows kind of the tiered effectiveness of methods. So on the top tier, we see the methods that work, as they say, really, really well. So we have long-acting reversible contraceptives, including the implant and the IUDs, as well as sterilization, which I will say is not a method that we discuss readily with our adolescent patients. But and then on the right, we see pretty low risk of getting pregnant, less than 1%. And then the next tier down, which works pretty well, includes the pill, the patch, the ring, and the shot. And slightly higher risk because they're a little bit more user dependent, somewhere between 6 to 9% of pregnancy, depending on the method. And then kind of the third tier down works not quite as well. So pulling out fertility awareness, these are methods that we're certainly not recommending as first choice for patients who really are not seeking a pregnancy. And then barrier methods, which we always recommend for prevention of STIs, but not as not the best choice for a first line contraceptive method. And this kind of third tier, somewhere between 12 to 24% risk of pregnancy.
Your call cannot be completed as dialed.
So I will say that over the past 10 years or so, our medical societies have put forth really strong recommendations to promote LARC as superior methods of contraception. And the American Academy of Pediatrics position statement from 2014 suggests pediatricians should be able to educate adolescent patients about LARC methods, including the progesterone implant and IUDs. And given the safety, efficacy, and ease of use, LARC methods should be considered first-line contraceptives for adolescents. And the American College of Obstetrics and Gynecologists also, as well as Society for Adolescent Health and Medicine, have been aligned with these recommendations for adolescents. And as such, LARC has really been on the rise over the past several years. So this data from the Guttmacher Institute shows LARC use among women aged 15 to 44 who use LARC methods, either the implant or the IUD. And we see that LARC has actually increased 7-fold between 2002 and 2018. So that's pretty significant. And similarly, we're seeing that adolescent use of LARC is increasing. So while total contraceptive use has only increased a bit, we see an increase from 3% to 15% between 2006 and 2019 in LARC use. However, it is really important to highlight that there's been substantial criticism about the messaging that the medical community has used in pushing these LARC and long-acting methods as first line. So we recognize that first and foremost, it's really important to promote a reproductive justice approach in offering contraception. And this LARC statement of principles was put out by the National Women's Health Network and Sister Song and reminds us that many of the same communities now aggressively targeted by public health officials for LARC have also been subjected to a long history of sterilization abuse, particularly people of color, low-income and uninsured women, Indigenous women, immigrant women, women with disabilities, and people whose sexual expression was not respected. And this statement was signed by over 100 organizations and is something we really all should be thinking about when approaching contraceptive counseling. So knowing that LARCs are one option and not the only option we should be promoting for our patients, let's talk about the different methods and what we know about them. So first we have the levonorgestrel or progesterone IUDs. And there are currently 4 different hormonal IUDs on the market today, including the Mirena and the Liletta IUDs, which are both the 52 milligram levonorgestrel devices and are identical in size and dosing. And then the slightly smaller IUDs, the Kylena and Skyla, which are 19.5 and 13.5 milligrams of levonorgestrel, respectively. Now, the lower dose IUDs are just slightly smaller in size as well as dose, and specifically Skyla is really promoted and approved by the FDA for nulliparous people. Although our experience has been that most youth have no difficulty accommodating insertion of the 52 milligram IUDs, and in fact often prefer them due to a much more manageable and lighter bleeding profile. And the progestin IUD works by thickening cervical mucus. It thins or atrophies the endometrial lining and makes it less hospitable for implantation. It inhibits sperm, and unlike with most hormonal methods, there's only partial inhibition of ovulation with the IUD, which occurs about 30% of the time. And in terms of duration of use, Mirena and Liletta are both now approved for 7 years, which is great. Kylena is approved for 5 years, and Skyla is approved for 3. And while it's wonderful that we have contraceptive options that do have such a long duration of use, we always like to remind our teens that if they're not pleased with their IUD or really any method of contraception for that matter, they are not obligated to keep it in or make a quote contract with a provider to give it a certain trial period, which in the past we had sometimes talked about with different methods. And we like to remind them it's their body, their choice. So counseling considerations for the IUD, very low failure rate. So typically about 0.2% after 1 year. It's also really important to talk about there is some discomfort with insertion. We don't like to sugarcoat this. We like to be upfront and honest and help prepare our teens for what they might expect if they decide to go this route, and talk about ways they can make the procedure more comfortable or understand it better before getting started. Helpful to talk about the fact that there probably will be cramps and irregular bleeding, especially for the first few weeks or even months. And while bleeding profiles are generally a lot less than prior to insertion, there may be some irregular bleeding and spotting. Generally, though, in the Mirena and Liletta IUDs, there's about 90% decrease in both bleeding and cramping, which is really substantial. We also have the Paragard IUD. So this is the hormone-free option that has copper only. It's the only hormone-free option we're talking about today. And the mechanism of action is that the Paragard releases copper salts that create kind of a foreign body reaction in the uterus, and it impairs the function of sperm. So Paragard is approved for up to 10 years, but it's likely effective for up to 12 years. And in terms of counseling, again, very low failure rate at 0.8% after a year. But it's really important to mention that patients often have heavier periods and sometimes even more severe cramps with the Paragard. So this isn't a very popular choice with adolescents, particularly ones who are seeing for support around painful or heavy periods, but it certainly is an option out there. And then the Nexplanon, which is the subdermal implant. So we describe this as a kind of matchstick size rod of plastic that's embedded with hormone. It has 68 milligrams of levonorgestrel progestin. And it works by inhibiting the luteinizing hormone surge, which prevents ovulation. It also causes endometrial atrophy and increase in cervical mucus. The Nexplanon is approved for 3 years, but there's good evidence to support that it is good for 5 years. So that's usually how we're counseling our patients. It is radiopaque in the rare case of migration, which is very unlikely now that we kind of have changed the way we place the device, but that is a helpful feature. And in terms of counseling, typical failure rate is extremely low, in fact, the lowest of any contraceptive method, so 0.05% failure. And we usually counsel that somewhere between 30 to 40% of patients will experience complete amenorrhea, although sometimes that can take a while. And it's very common, particularly with the Nexplanon, to have irregular bleeding. Sometimes it resolves within 3 to 6 months, but not always. We certainly do have methods to help with bleeding, including adding on a hormonal pill or taking NSAIDs, which can diminish bleeding. But it's important to be kind of upfront about that expectation. Unfortunately, we do not have good studies of contraceptive efficacy in women with BMIs over 28. And so new research needs to be done. Okay, and so let's talk about another case. Here we have a 15-year-old cisgender female who comes into clinic with really heavy and painful periods. She would like to know what her options are for alleviating her symptoms. She also has moderate acne and worries about hormones and their impact on her skin. She has no contraindications to estrogen, and she's really not interested in a long-term method, so doesn't even want to hear about that. So what options might you consider? So, well, all the hormonal methods will work well for dysmenorrhea. In patients who have acne, you might think about an estrogen-containing medicine specifically, as they can diminish circulating progesterone testosterone and androgen levels, which can help with acne or hirsutism. So, what are the combined hormonal methods? These are pills, patch, and ring. And again, these contain both estrogen and progesterone. So the mechanism of action is that estrogen actually works to suppress follicle-stimulating hormone, and so there's no follicular development. It also increases intracellular progestin receptors, and for those patients who have heavy or abnormal bleeding, it stabilizes the endometrial lining to minimize irregular bleeding. And the progestin, again, similar to what we've seen in the next one, suppresses that mid-cycle LH surge and prevents ovulation, also thickening cervical mucus. So important to mention that the big risk we worry about, as alluded to earlier, is venous thromboembolism in patients who are taking estrogen. So while there is good evidence that CHCs or combined methods are associated with an increased risk of clot, we have a lot of controversy around kind of the actual risk associated with different methods. But overall, we think there's about a 3 to 5 times increase in patients taking combined oral contraceptives compared to patients who are not, and probably around a 10 to 35 times higher risk in patients with factor V Leiden who are on combined contraceptive methods. So the absolute risk of VTE does remain low. So it's really in kind of a young, healthy person who's assigned female at birth, the rate is less than 0.5 in 10,000 people. But it increases to about 1 in 10,000 while being on a combined contraceptive pill. That increases to about 3 in 10,000 with the contraceptive patch, which we'll discuss later. And then a big jump up to somewhere between 5 to 20 in pregnancy and 40 to 65 in the postpartum time. So bottom line is that really all types of contraception are much safer than pregnancy, if that's the consideration that you're making. And VTE really is the highest during the first 1 year of initiating pills or contraceptive methods, but even more so in the first 3 months. So where do we even start with pills? There are so many different combinations and preparations that it's overwhelming to many of us. So important to know that pills mainly differ from each other by the dose of estrogen and then the type of progesterone. And then we have, of course, monophasic, triphasic, biphasic, adding another level of complexity. So in terms of monophasic pills, this means that there's a constant dose of estrogen and progesterone in each active pill. And lower dose estrogen pills, meaning lower than 30 micrograms, are actually not ideal for use in teens because they can decrease bone mineral density in the long run, excuse me. But some really good go-to pills, if you want to keep in mind, are orthocycline or Sprintec, which is kind of our standard starting pill, mid-dose estrogen, 35 micrograms, which is a pretty good, and norgestimate, which is a pretty good progestin that has some anti-androgenic activity, which is helpful for acne or hirsutism. So this might be a good pill that we would start our patient in the case on. Another good pill to know about is the Cresel low overall, low ogestrel pill, which again is a mid-dose estradiol pill with actually a different progestin, which is a bit more stabilizing. So this is a pill that you might use for someone who has really heavy or uncontrollable bleeding. And this is a pill that we often see used in acute situations in the ER for patients who come in with heavy bleeding. And then we have biphasic, triphasic pills. That really means there's kind of a gradually increasing dose of estrogen or progesterone during the cycle, initially kind of created to mimic more the natural physiological changes in a menstrual cycle. And one example of this that you may have heard of is orthotricycline. But these pills are really not generally advised for use in teens. There's often a lot more breakthrough bleeding and confusion about missing pills and jumping to kind of different doses at the wrong time. And they're really not great evidence about superiority to monophasic. So we would recommend sticking with monophasic pills for teens. So in thinking about common side effects associated with pills and really any of the contraceptive methods that are combined containing estrogen are nausea, breast tenderness, and breakthrough bleeding. And again, these are mostly estrogen related. We usually recommend coming in for a follow-up visit sometime around 3 months after initiating a method to monitor for side effects, but also potentially provide reassurance and switch methods if necessary. So failure rate is pretty low for perfect use, about 0.3%, but we know how hard it is for any humans to stick to a daily regimen, and so typical use is closer to around 7%. So there is actually a great app out there for any of you who find yourselves either prescribing or frequently looking up different OCPs to figure out what medications they contain. And there are so many generic and brand name medications out there, so this is very helpful. Unfortunately, I think this costs about $4, but it's very worth it for anyone who sees teens regularly. So here is kind of the main screen that you see when opening the app, and you can either search by pills through A through Z, which is super helpful if you just have a name of a pill and want to throw it in. You can also look by estrogen dose or type of progestin. You can also look by kind of special features, which might be helpful in case, for example, you have a patient who needs to have a crushable pill for a G-tube or something along those lines. And here's just a visual of the kind of progestins by type. And I like to show this to illustrate the kind of different levels of androgenicity that I've alluded to. So on the top, you see kind of the higher androgenic activity. So those are pills that might not be your first choice for somebody who is coming in seeking treatment for acne, but they are a bit more stabilizing, so better for the bleeding. And then on the bottom, you see progestins such as progesterone, which is the progestin in Yaz or Yasmin, which is FDA approved for treatment of acne. Excuse me for 1 second. Okay. And then further here on the right side, we see this is a screen that pops up if you actually select one of the pills. And not only does it give you kind of a thorough review of what the estrogen dose is, what the progestin type and dose is, and kind of the category of pill, but also my favorite part is that it shows all the equivalent pills. So if you just are wondering kind of what other names your patient might expect to receive at the pharmacy, this is a helpful view. Excuse me. Okay, then we have the contraceptive patch. So this is a patch or sticker that delivers 20 micrograms of estrogen and 150 of norelgestrones. Excuse me. It does have higher levels of circulating estrogen based on the transdermal effect, which does mean there is a slightly higher risk of clot or venous thromboembolism. The pill is changed once a week for 3 weeks, and then the 4th week is a patch-free for withdrawal bleed. Patients are advised to rotate sites and really avoid the breast area because of the hormone impact. It is unfortunately less effective in patients with a higher BMI. And perfect use failure rate is less than 1%, and typical use is closer to about 8%. I'm sorry about my voice. The Twirla patch is actually a new patch that is just hitting the market. This is a 30 microgram patch, but it actually is systemically only seems like a lower dose of estrogen to the body. So there's theoretically a lower risk of clot with this patch. Unfortunately, it's still quite expensive, and so is not really readily available for most populations. There's also a vaginal ring, which is the Nuva ring, and this contains 15 micrograms of estrogen, 120 micrograms of even progesterone daily. And the ring is left in for 3 weeks and removed for 1 week to allow for withdrawal bleed. It can be removed for up to 3 hours and then reinserted. And it's actually a really great method for menstrual headaches due to the kind of totally continuous estradiol dosing and no fluctuations with estrogen. A common side effect, though, is increased vaginal discharge, which is really important to counsel patients on. And some people really don't like the idea of having to put something in their vagina every month. Perfect use rate is about less than 1%, and typical rate is closer to 8%. We also actually have a new ring that is, again, quite expensive and not readily available to the public, but it's a 12-month contraceptive ring. So thinking about kind of improving opportunities for reproductive autonomy, this is a great option for patients. It's again kind of leave-in for 3 weeks, out for 1 week for withdrawal bleeds, but again, not super available readily yet. Okay, so let's talk about another case. Case 3, we have a 14-year-old assigned female at birth, non-binary youth who uses he, they pronouns and presents to clinic endorsing significant dysphoria with menstrual cycles. He would really like to stop having periods altogether. He has no past medical history and no contraindications to estrogen. So what are their options? So really, this is a situation where any hormonal method can be used. It's important to kind of review all methods and amenorrhea rates with your patients. And some patients may wish to avoid an estrogen-containing medication if it doesn't align with their gender-affirming goals, but others actually may prefer one based on the side effects or other kind of symptoms they're hoping to avoid. It's also, of course, important to assess for any unmet contraceptive need and make that a part of your decision making. But this is a really great way to provide gender affirming care, especially if patients are waiting to get into the gender clinic or not able to be affirmed in other ways. So how many of you have had a parent ask or have even wondered yourself, is it safe for my child to skip their monthly cycles? This is a question that we get all the time, and it's a great question. So the short answer is yes. It's important, I think, to review that if a patient presents with an abnormal cycle or amenorrhea, it is important to kind of rule out any medical etiologies, but if they're healthy and desire suppression of menses, that is perfectly safe. The hormonal effect of any contraceptive method is thinning the lining of the endometrium, so that prevents any buildup. And this, does not affect fertility in the long run. So I think those are really great reminders and things that we can tell our patients. And just a reminder that menstrual suppression is a really great option as well for patients who might have developmental delay or caregivers who are hoping for support around hygiene, and patients with abnormal uterine bleeding who really are having decrease in their quality of life based on their bleeding cycles. So What do we know about the risks of continuous oral contraceptive use? We've kind of thought it's safe, but we actually had a new paper that came out this year that confirms what we've suspected. And this study was looking at OCP users from 2006 to 2017 in the US. It was a massive healthcare database, and it looked at over 100,000 treatment events or encounters. The outcomes of interest they were looking at were venous thromboembolism and arterial thromboembolism. And what did they find? They really did not see a significant difference between the continuous 91-day oral contraceptive pill, which you may have heard of as Seasonique, compared to a standard 28-day pill. The exception to this, I will say, is that we cannot use a continuous patch without taking a withdrawal bleed because of the increased venous thromboembolism risk that I alluded to before. But this evidence is helpful and supports what we previously thought. So getting back to our case, so our patient reports that they are not interested in implants or IUD. They don't want to hear about those, and they would actually prefer to avoid methods that contain estrogen. These really don't align with their gender goals. So what are the options that you want to tell them about? So now we'll talk a bit about some other progesterone-only methods that we haven't discussed already. One option is the norethindrone pill, or the mini pill, which has a really tiny dose, 0.35 milligrams of norethindrone daily. This is a pack that does not have a placebo week. It contains 28 days of active pills. Common brand names you may have heard for this pill are Orthomicronor, Camilla, and Erin. The mechanism of action is that, again, the progesterone thickens the cervical mucus, makes the endometrium less amenable for implantation. Effects are really the highest about 2 hours after administration. And the important thing to note is that this is a really tricky pill because it does not consistently suppress ovulation. So it really needs to be taken within the same 2-hour window daily, which is really hard for most humans, let alone adolescents. So the failure rate with this pill is a bit higher, somewhere between 1% to 9% in the first year of use. Excuse me. And about 40 to 50% of patients will have short monthly menses, but ovulation is not, again, consistently suppressed. So unscheduled bleeding is pretty common with this pill. Another kind of new option on the market is a drospirenone-only pill, a progesterone-only pill, which contains 4 milligrams daily of drospirenone. It has 24 days of active pills and 4 placebos. And this is a 3rd-generation progestin, so it actually has a little bit of anti-mineral corticoid activity. It's kind of comparable to a low dose of spironolactone, about 25 milligrams. So it's not safe for patients who have renal failure or issues, and it is important to monitor potassium levels in patients who might be at risk for hyperkalemia. It does inhibit ovulation, and typical failure rates are pretty low, 1.8%, and with perfect use, about 0.7%. So this pill actually has a much longer half-life than norethindrone or the mini pill, so there's much less risk of pregnancy, and the bleeding profile is much better. So that's a great option, especially for our patients who are seeking gender-affirming care and need contraception. We also have a higher dose of norethindrone-only pill, which is called Agestin. So this is a 5 milligram pill. I will say this is the one option today we're discussing that is not FDA approved for contraception, so that's important to know. The pill can be titrated up to a little bit higher than the 5 milligrams, up to 10 milligrams, or even on rare occasions 15 milligrams, but very short-term use. That can become unsafe if used for a prolonged period of time. And that's mostly because higher doses actually result in some peripheral conversion to estrogen. So if you're selecting this method because your patient has a contraindication to estrogen, it's just important to know you want to keep that dose pretty low. So Agestin does a great job at effectively suppressing ovulation, and it's excellent for menstrual suppression and a fairly safe and well-tolerated medication. So it's a good one to keep in mind. Another progestin-only option that we haven't mentioned yet today is Depo. So Depo-medroxyprogesterone acetate. This is typically given in a 150 milligram intramuscular injection every 3 months. And the mechanism of action, again, is that big dose of progesterone really suppresses the LH surge, preventing ovulation, thinning the endometrial lining, and increasing cervical mucus. It's helpful to know that Depo-Provera is actually the only form of contraception where we do have some evidence of weight gain as a side effect, including in adolescents. Particularly, that's more common in people who are already living in larger bodies, but just an important side effect to mention. And there can be decreased bone mineral density in patients who are using it for prolonged periods of time. So something to monitor for. Generally, injection is given within an 11 to 13 week window, and the pregnancy rate with perfect use is really low, 0.3%. We also have a new self-administered subcutaneous option for Depo, which is 104 milligrams. Same every 3 month duration of use, but again, maybe a good option for improved patient autonomy. Still pretty expensive, not readily covered, but one thing to hope for in the future. And I also want to point out that we have a really great handout on our Seattle Children's Hospital toolkit. This is menstrual suppression handout. So it really talks about kind of what does menstrual suppression even mean? Is it safe? What are my options? And the back of the sheet goes through really all of the methods. It talks about specifically the rates of amenorrhea or lack of periods. So that is just a really helpful overview for patients who are seeking it as a priority. Perfect. And what is a contraceptive talk without at least mention of the importance of barrier methods and safe sex practices? So we certainly always encourage a barrier method as the best way to prevent STIs and remind patients who are looking for prevention of pregnancy that 2 methods are better than 1. And always talk about the importance of at least yearly screening for STIs or with any change in sexual partner. It's also good to talk about emergency contraceptives. So we have a couple of different pill options on the market. Plan B is a 1.5 milligram levonorgestrel dose, which is FDA approved for emergency contraception within 72 hours of unprotected sex, but off-label it can be used up to 120 hours. It unfortunately does have waning efficacy, so best to take it as soon as possible after unprotected sex. The mechanism here is that it prevents follicular rupture and ovulation. So there is no effect on events after the LH surge or ovulation. So good to mention that this is not inducing an abortion. That's not how this pill works. It is over the counter, which is great. Although sometimes it's helpful to actually prescribe it to your patient so they don't have to pay as much and they have it at home in hand if needed. And there are no negative effects with repeated use. And then Ella is the other option, which is 30 milligrams of ulipristal acetate. And this is a great option because it provides more effective contraceptive for about 120 hours after unprotected sex, and it does not have a waning efficacy as time goes on. The other great thing about Ella, it is much more effective in patients living in large bodies compared to Plan B. So that's what we would definitely recommend. It unfortunately does require a prescription, and sometimes it's costly and difficult to find. Also, we have the copper IUD has been kind of known as an effective emergency contraceptive if used within 5 days of unprotected sex, but we now have evidence that the levonorgestrel 52 milligram IUD, the Liletta and Mirena, also have equivalent efficacy for emergency contraceptive to the copper IUD. So that's really great news. So we've touched on a few of these in our cases, but there are many uses for hormonal contraceptives, including, but not limited to, heavy menstrual bleeding, hematologic issues such as von Willebrand disease, thrombocytopenia, dysmenorrhea, endometriosis, ovarian cysts, polycystic ovarian syndrome, menstrual dysphoria, premenstrual dysphoric disorder or PMDD, migraine headaches, especially if they're hormonal, catamenial seizures, and developmental delay or menstrual hygiene. And added benefits of hormonal methods for all methods include, prevention of anemia and potentially iron deficiency, prevention of endometrial hyperplasia and decrease in endometrial cancer risk. And then estrogen methods actually, not only do they potentially have the anti-androgen effects that we discussed, but they can decrease risk of ovarian cancer and decrease risk of colorectal cancers, which I think is really helpful to share when our patients come in with many concerns about, long-term side effects of pills. And what are future strategies to improve access? So we will see what the future brings, but there's a lot of talk about pharmacist administered pills or even an over-the-counter pill. There's one kind of in the works now, a progesterone-only pill that might be available soon. And there are also a lot of emerging web-based telehealth companies that offer contraceptive counseling and can be great options. So a few of those are Pandia Health, HERS, and NERCS, acknowledging that these strategies are only going to improve access for certain patients and populations, but they're still out there and promising. And what's next in contraception? So there actually is some emerging research on extended release monthly pills, vaginal rings with potentially a dual HIV and STI protection with a mesh barrier, microarray patch, even a male contraceptive methods, including gels and pills that they've been working on for years. And there are some environmentally friendly options that are coming down the line, including a bunch of vegan contraceptive methods, since a lot of birth control pills contain lactose, and a plastic-free IUD with a different type of frame. So in summary, there are many, many uses for hormonal contraception in adolescents beyond just birth control. Sexuality is a normal part of adolescent development. And a reminder that in working with a patient to help select a method, just ensure that you are always prioritizing their goals, maintaining patient confidentiality, assessing for any medical contraindications, considering LARCs as effective and safe for teens, and really utilizing a reproductive justice approach above all. So I just wanted to share a few great resources for teens and for providers. So the Center for Young Women's Health, although a bit gendered in the title, a really wonderful site that is put out by the folks at Boston Children's Hospital, has some great patient and family forums and provides just really great thorough medical information about all things reproductive health. Bedsider is also a wonderful site for providers and patients with great visuals and handouts, including that 3-tiered visualization that I showed with the different methods. And the Power to Design is also a great site that you should check out. And then finally, I just wanted to put in a plug for our adolescent medicine clinic and our awesome group of providers who work across the street at Springbrook Clinic. So just a reminder that we offer contraceptive consultation, including menstrual management and LARC placement, both inpatient and in our outpatient clinics. We even have a dedicated LARC clinic on Wednesday mornings every week. And as many of you know, we have a gender clinic where we often routinely offer menstrual suppression. And we are very happy to talk to you about your challenging cases or see your patients. So please send them our way. And we also work with really wonderful pediatric and adolescent gynecology providers who are able to place IUDs under anesthesia in the OR, provide more complex contraception, including for transplant patients and patients with bleeding disorders, as well as patients with any kind of structural or anatomical concerns. So if anyone has any questions about placing a referral, we're always happy to discuss that. So that is all I have. Thank you so much. Stop sharing.
Thank you so much. We already have a comment in the chat from Dr. Bruner. Thank you so much. Fantastic and informative talk. Grateful always for our amazing adolescent medicine team. Agreed. And for the rest of you, if you have a comment or question, feel free to type it into the chat, or we can see, I think we have a small enough group that we can see if you want to either raise your hand or just unmute yourself and ask a question or say a comment. I think we are all good enough at WebEx to be able to handle that this morning. We have about 6 minutes for discussion and questions. And several, I don't know, Sarah, can you see the chat? Just several thank yous for this great and comprehensive talk and for your team. So thank you. I want to make sure you see those as well.
So thank you so much.
And some great references. We really appreciate that too. Some of the PCPs are here and planning to use your references. So thank you.
Perfect. Just what we want.
Oh, from Dr. Evans, wonderful presentation. Thank you. Wondering if you have recommendations on confidential prescribing.
Yolanda, yes, I think that is such a great question and such an important one. I don't think that we have really come to a conclusion about the best way to confidentially prescribe. I think especially in the era of electronic health records. I think what we have done, especially in cases with patients who needed confidential STI treatment, we have kind of called the pharmacy ahead of time or asked the patient to select a different pharmacy that their parent might not be getting, a text alert if a medication is ready for them. And if the patient is able to pay without going through insurance, that's one option. Certainly that is not a great long-term solution or something that works for everyone, but I would love more thoughts on that if anybody else has them. I think we're still working to figure out the best way to support our patients around that. Thank you.
Oh, from Dr. Bruner, do you need parental consent to suppress menses in those seeking gender affirming care?
Yeah, that is a great question, Cora. Thank you so much for that. No, you do not need parental consent. So this would fall under kind of that confidential reproductive health care in Washington State, which does not have a lower limit for age. And it's certainly not a gender affirming hormone therapy like testosterone or estradiol, where we would need parent consent to move forward with that. So great question. And again, this is like kind of low hanging fruit, a really awesome way you can affirm your patients in your primary care clinic, or just give them a little support around one piece of gender dysphoria if that is helpful to them. So thank you for that question.
Great. And we have a comment in the chat too. Partnering with school-based health clinics when patients have access can be a good way to promote confidential prescribing. That's a great comment. Thank you.
Great comment. Thank you so much, Gwen.
I have a question just from my perspective, because I work in the emergency department. What is the wait time to get into one of your clinics? And can families self-refer? Can patients self-refer? Or do they need a PCP referral in all situations?
Yeah, that's a great question, Suzanne. I don't know what the actual wait times are right now. Yolanda might be able to chime in about that. I know that certainly for eating disorder care, we do require a referral from a primary care provider. But otherwise, patients are mostly able to self-refer. For certainly any gender care, reproductive health care, we don't necessarily need referrals. And we do have a pretty large number of reproductive health providers. So I think that waitlists are fairly shorter for that compared to gender care and eating disorder care. So
great.
Yeah.
So even teens can self-refer and get into that clinic without parental involvement if needed?
I believe they can. I think, and again, I'm not the best person to answer this, but I think that they do need to have an ambulatory consent signed by a parent at some point if they're under 18. The content of the visit can certainly be confidential, but I might have to defer to my clinical leaders on that. But I believe that they do need an ambulatory consent that's signed by a parent.
Thank you.
Yeah,
that makes sense. It's tricky.
It is, yes.
And Dr. Evans, Yolanda is saying for contraception, self-referral, and the LARC clinic is pretty open, but yes, the institution needs ambulatory consent.
Yes.
So it sounds
yes,
like
absolutely.
Somewhere along the way, a consent needs to be on file, and then the child or the teen can self-refer, is what I'm understanding. Okay, thank you. That's really helpful to me.
Thank you, Yolanda. Yes, we have a lot of access in our LARC clinic. We have more and more providers who are able to perform those services, and lots of trainees who want to be part of that experience too. So, so I think we're always happy to accommodate LARC patients very quickly.
Great. That's great to know. And the team can come alone per Yolanda Evans. That's great. And then from Liz Abernathy, can you speak to the Washington state law that mandates pharmacies to supply patients with a year's worth of birth control if desired? Huh.
Yeah, thanks, Liz. That's a great question. I'm not sure fully about the kind of historical origins of that. I believe that that is just kind of another way for us to advocate for getting sufficient medication to our patients and not having kind of barriers to contraception. And I know that certain insurance companies will actually only fill if you provide a full 365 days. But yeah, that's a great question, and I'll have to look a little bit more into that. Thanks, Liz.
Thank you. All right. Well, it's exactly 9 o'clock, so we're out of time. This was a really, really great discussion. And thank you so much for all of your work in this amazing talk. I learned a ton, and we all have a lot more to consider and learn. I'm so excited that your clinic is open and available to, and all the work that all the folks do in adolescent medicine. We really, really appreciate you. So thank you so much. Thanks to all of our viewers and participants for being here. And thanks, Dr. Golub. And we'll see everybody next week.